Hello everyone, myself Dr. Amit Patle. I am JR1 in the Department of Radiodiagnosis at Aiims Bibinagar, Hyderabad. Today, I am going to present a clinical case. So, 14-year-old male came to surgery OPD with chief complaints of pain over scrotal region since 3 days and swelling over scrotum region since 3 days. There is no history of trauma. Then patient referred by surgery department to the radiodiagnosis department for ultrasonography, and look over here, this is the left testis. Does it appears normal? Yes, it looks normal. Yeah, we can see here homogeneous ecotexture in the left testis, and yes, this is normal. While look over here, this is the right testis, and here we can see that there is heterogeneous hypoechoic areas with loss of vascularity, both arterial as well as venous. While look over here, this is the left testis which is normal, yeah, and here we can see that there is vascularity on the CDI. So yes, left testis is normal while right testis is appears heterogeneous and hypoechoic. Now look over here, this is the spermatic cord, and we can see that what is this? Yes, this is the whirlpool. So if we turn our probe in the transverse position, and then we can see that there is sensitive and specific sign, that is so called real time whirlpool sign, and this sign is characterized by a spiral twist or rotation of the spermatic cord. So yes, here we can say that there is twisting of the spermatic cord. Following rotation of the spermatic cord, blood flow to the testis is compromised. That might leads to complication like severe ischemia and acute pain. Okay, so that's why we did color Doppler imaging for assessment of the blood flow to both the testes. Look over here in the next USG image, we can see that there is 0.76 resistive index in the testicular artery in the right testis. We can say that there is elevated resistive index in the right side, while we can see here in the left testis the testicular artery resistive index is about 0.59. So it is normal. Okay, now also while doing ASG we notice that there is cortical sac thickening and there is associated thickening of the right epididymis. So diagnosis is these all features are suggestive of complete torsion of the right testis. Now let's talk about few important things about testicular torsion. So why we are studying this topic today? Because testicular torsion occurs in about 1 of 4,000 males aged less than 25 years and accounts for about 25 to 35 of acute pediatric scrotal disease. So yes, it is important to know about this condition. Testicular torsion is caused by twisting of spermatic cord which compromises venous and arterial flow. It is a pediatric urological emergency because it can lead to irreversible testicular damage and loss of the testes. So, diagnosis must be promptly made, usually within 6 hours, to ensure testicular viability. Now, what is the supply of the testes? It is mainly supplied by testicular artery and also supplied by cremasteric artery and pampiniform plexus. So, I said my diagnosis is complete testicular torsion. So, why I said this? So, here because there are two types of torsion, incomplete torsion and complete torsion. So, in incomplete torsion, there is elevated resistive index, that is more than 0.75, and there is to and fro flow of the blood. While in complete torsion, there is absence of blood flow in both the testis and epididymis. That is complete torsion. So in my case, there is absence of blood flow in both testes as well as in epididymis. That's why it is complete torsion. Now, what is the ecotexture? So yes, ecotexture can be homogeneous or it can be heterogeneous. So homogeneous ecotexture is early finding and it is before necrosis, and heterogeneous ecotexture is a late finding after 24 hours and implies necrosis. Hypoechoic region represent necrosis while hyperechoic regions represent hemorrhage if the testis is reperfused. So yes, there can be reactive hydrocele, or there might be reactive thickening of scrotal skin with hyperemia and increased flow on color examination. But yes, before giving it a diagnosis, first it closely mimics epididymoorchitis. So, how can we differentiate it? The only way to exclude torsion from the differential as epididymoorchitis is if changes are entirely confined to the epididymis with a complete normal testis. That's how we can differentiate it from epididymoorchitis. The likelihood of salvage of the test is directly related to the time between onset and detorsion, whether it will be surgical or spontaneous. If it is less than 6 hours, then 100% salvage. If it in between 6 to 12 hours, about 50%, while 12 to 14 hours is 20%. So as intermittent testicular torsion ultimately may progress to acute infarction. The management of this testicular torsion is very important because the key to successful treatment is rapid diagnosis and surgical intervention because it is a urological emergency. So yes, patient should be kept for nail by mouth for surgery, analgesia is given, and there is surgical exploration. So there are two types of surgeries can be done. The first one is orchiopexy, where the position corrected and fixed in a place, and the second one is archidotomy, where there is removal of the testes if there is delay or if there is necrosis. So this is how we manage the patient. So yes, this is all about the testicular torsion. Thanks for watching this video and stay tuned for the next one.